morning, everyone. On behalf of Department of Physical Medicine and Rehabilitation and Physiology, I invite you all for this month's postgraduate combined from PGCR. So, our today's presentation is sports injury rehabilitation. Sports injury rehabilitation generally less reported, but it is a quite common incidence during daily routine day-to-day sports activities, with incidence of 1.79 to 6.36 injuries per 1,000 hours of participation. Injuries in sports can be contact, non-contact, oval injuries, and acute. They may involve either soft tissue, bony structure. Epidemiological studies have revealed no significant increase in sports-related injuries over the past 2 decades, despite the heightened insight into injury mechanism, prevention program, and load monitoring techniques in athletes. If we divide rehabilitation is divided into 2 parts. Again, habilitate, make fit. It is a process designed to minimize the loss associated with the acute or chronic disease, to promote recovery and to maximize functional capacity, fitness, and performance. Goals of rehabilitation are limit the extent of injury, reduce or reverse the impairment and functional loss associated with injury, and prevent or correct or eliminate altogether the disability. And these are basically few of the rehabilitation components that involves pain management, flexibility and joint range of motion, strengthening and endurance program, proprioception and coordination, functional rehabilitation, and use of orthotics. I'll start today's presentation with our today's presentation is divided into 4 parts that involves first basic of sports medicine, sports injuries, that will be presented by Dr. Himanshu, physiology of sports injuries, Dr. Sanjay Choudhary from Department of Physiology, assessment of sports injuries, Dr. Regdhara Mishra from Department of PMR, and sports injury management and rehabilitation, second year resident Dr. Meghna Khatri, Department of Physical Medicine and Rehabilitation. Now I invite Dr. Himanshu Ahuja to start with basics of sports injuries.
Thank you, sir. I am Dr. Himanshu Ahuja, first year resident, Department of Physical Medicine and Rehabilitation. Today we shall be discussing on basics of sports injuries. The basics of sports injuries topic begins with its classification, which can be subdivided into based on time of onset, tissue type involved, and the type of sport. It may further be elaborated with acute or chronic, muscle, ligament, bone, and contact and non-contact sports, which shall be discussing further. So, based on time of onset, the injuries can be acute or chronic. Acute are usually due to a single traumatic event, while chronic are due to repetitive stress and micro traumas. So, with acute injury, it may be a fall, a tackle, a direct blow, or an awkward landing, which can result in acute injury. It usually causes immediate pain, swelling, and loss of function. Example being sprains, fractures, dislocation. While chronic or overuse injuries, they develop more gradually. Repetitive microtrauma develops when body is not given enough time to recover. They are common in endurance sports involving repetitive motion. Examples include tendinitis, stress fractures. Athletes often ignore early signs leading to worsening of symptoms over time. Early detection and rest are appropriate for timely recovery. Moving on with the discussion, here we have a video of a gymnast who suffered from tear of anterior cruciate ligament. As she lands, she'll hear suddenly a pop sound due to tear of anterior cruciate ligament, because a sudden twisting and pivoting at the knee as the direction changes, which ruptures in an instant the anterior cruciate ligament. The athlete feels a pop followed by swelling and instability. Then we have an iconic video from 1992 Olympics of Derek Redmond, which ended his career due to a hamstring pull. As the runner accelerates in sprinting, the hamstring contacts powerfully. If muscle isn't properly warmed up or fatigued, it can tear, leading to sharp pain in the back of the thigh and immediate difficulty in continuing the activity. Moving further, we have a tackle in rugby, where the player in blue dress suffers from a shoulder dislocation. The force of impact, especially when arm is extended, can push a head of humerus out of its socket, leading to intense pain and visible joint displacement. Prompt reduction and rehabilitation is the key. Then on we have 2 more photographs of acute injuries, that is clavicle fracture and contusion. So for acute fractures like a fall from cycling, when cyclist falls off the bike and lands on shoulder or outstretched arm, it's the collarbone that often takes the impact, and there is painful break, swelling, and obvious deformity over the shoulder region. Then there is contusion or bruises, that is a direct blow to soft tissue, a quadriceps contusion, which might occur in contact sports like hockey or martial arts. A strong impact in front of thigh can rupture small blood vessels, leading to bleeding within the muscle, swelling, and difficulty in moving the leg. Then we have chronic or overuse injuries, the example being Achilles tendinopathy, usually seen in long distance runners. This happens when tendon at back of ankle is overused, or we have tibial stress fractures, which shall be further elaborated by other presidents. Like in marathon runners, the tiny crack in the shin bone caused by repeated impact usually starts with mild pain and worsens over time, especially during the activity. Then we have subacromial bursitis, commonly seen in swimmers. Subacromial bursa, fluid-filled sac in shoulder. It causes pain when lifting the arm or doing overhead movement. Then on base of tissue type involved, we have the discussion for basics of sports injuries into three subparts, that is soft tissue injuries, bone injuries, and cartilage injuries. For soft tissue injuries, we have muscle strains, which on the basis can be divided into a small tear to a complete tear. Then we have tendon injuries. For tendon injuries, we have tendinitis, tendon rupture, and tendinosis. Example being Achilles tendinopathy, as discussed earlier. In tendinitis, the tendon becomes inflamed or swollen. It occurs suddenly after overuse or injury. In tendon rupture, the tendon is torn either partially or completely. While in tendinosis, it's a long-term problem. As tendon wears over time, the tendon may not be swollen, but is often very weak and damaged. Then we have ligament injuries. The ligament injuries, the sprain is divided into three categories. It may be a small tear, a large tear, or a complete tear. Then moving on, we have bone injuries. It may be a traumatic fracture, a stress fracture, a Wilson fracture, apophysis, periostesis, or osteochondral injury. Traumatic fracture are usually due to acute high impact break. Then stress fracture is due to repetitive load or microfractures. Avulsion fractures is when tendon or ligament pulls off a bone fragment. Apophysis is for overuse at growth plates. Then there is periostitis, that is the periosteal inflammation, and osteochondral injury where both cartilage and bone are involved. The cartilage injuries are integral to assessment and management. In PMR, physical medicine rehabilitation, the 8 conditions in determining severity and formulate appropriate treatment strategies. The common classifications being Outbridge classification, International Cartilage Repair Society classification, and Modified Novice classification. The most common being Outbridge classification used is being discussed here. It involves the defect of cartilage injuries in 3 further categories, grade 0 being normal, second being a partial thickness defect, then third being a full thickness defect, and the fourth being a osteochondral where the both bone and cartilage are involved. Thank you, and I would like to welcome Dr. Sanjay Choudhary from Department of Physiology to continue the presentation.
Thank you, Dr. Himanshu. Good morning, everyone. I am Dr. Sanjay Choudhary, first year graduate, Department of Physiology. Today, I shall be presenting physiology of the sports injury. Physiology factors for determining speed. Fast twitch muscle fibers. The greater the percentage of the fast twitch fibers, faster the speed is. Explosive strength. More explosive strength leads more speed. Neuromuscular response. Higher and faster neuromuscular response. Faster is stronger than muscular contraction, which increase speed. ATP energy store. More ATP store, faster is the energy release, which help to improve the speed. Physiological factors determining endurance. Maximum oxygen intake. More amount of oxygen taken up and utilized during exercise will improve the endurance capacity. Pulmonary diffusion. It is the exchange of the oxygen carbon dioxide between the lung and blood. More and faster pulmonary diffusion improve endurance. Cardiac output. More cardiac output have to working tissues. It improves endurance. Lactic acid tolerance. More lactic acid tolerance, delay fatigue and tiredness, which improve the endurance. Physiological factors determining flexibility. Muscle strength. Flexibility depends on the level of the strength. Increase muscle strength, it can enhance the flexibility. Joint structure. Joint attached to the various muscles, ligaments, cartilage, and tendon, which make the joint strong and flexible. Ligament elasticity. More the elasticity of the ligament, increase the flexibility of the joint. Age and gender. Flexibility decreases as the age progresses. Female are more flexible than male. Disease. Many types of the disease and all injury affect the flexibility. Effect of exercise on respiratory system. Increase in tidal volume. With regular exercise, tidal volume and vital capacity of the lung increase, by which more oxygen reaches to the working tissues. Decrease in rate of respiration. Regular exercise decrease respiration rate during rest. Increase in aerobic endurance. With regular exercise, less amount of the lactic acid produced, which results delay, fatigue, and fatigue. Effect of cardiovascular system. Increase in cardiac output. Exercise increase the cardiac output, which increase the blood flow. Decrease blood pressure at rest, reducing the cholesterol level of the blood. Exercise of the effect of exercise on the muscular system. Shape and size of the muscles. Regular exercise change the shape and size of muscles that improve muscular capacity. Formation of more capillaries. Exercise increase the number of capillaries which help faster blood circulation. Delay fatigue. Regular exercise increase the ability of the muscles to tolerate more lactic acid for longer duration, which delay muscle tiredness. Desired strength development. Systemic and scientific training can develop the desired strength and endurance. Better neuromuscular coordination. Regular exercise improve neuromuscular coordination, by which various skills can be performed efficiently. Increase in aerobic and anaerobic endurance. Trained muscles have more aerobic endurance. Capacity of the muscles increase to work for longer duration without fatigue. Thank you. Now I would like to invite Dr. Regdhara Mishra for Department of the PMR for continuing the presentation.
Good morning, everyone. I'm Dr. Regdhara Mishra, first year resident from Department of Physical Medicine and Rehabilitation, and I'll be discussing about history and assessment in sports injuries. Starting with injury assessment protocol, which is a systematic approach used in evaluating sports injuries, we begin with the history of injury, where we focus on the primary complaint, mechanism of injury, and evolution of symptoms, understanding the background which gives us clues about the possible damage. Next is observation, where we assess the overall state of the patient, look for visual signs such as asymmetry, swelling, or abnormal posture. Following that is inspection, which involves more detailed visual assessment. We look for localized deformities, scars, bony, and soft tissue irregularities. The fourth step is palpation, where we apply gentle pressure to assess tenderness, tissue tension, or any pain response. This will help us to pinpoint the affected structures. Finally, we perform physical examination tests. These include functional test, ligamentous and capsular test, neurological screening, and sport-specific tests to assess joint stability, muscle function, and nerve involvement. So we begin with primary complaint, where we ask the athlete to describe their current issue, including the nature of the complaint, its location, and onset. Next, we look into mechanism of injury. This includes asking how the injury occurred, such as direction of force, movement of the limb, or any change in equipment, shoes, or training techniques. Third section is characteristic of symptoms. Here we gather details about the location, severity, duration, and behavior of the symptoms, like whether they worsen with activity or improve with rest. We also explore the disability resulting from injury, which includes limitation in sports performance, occupational duties, or daily activities. This gives us insight into how the injury is impacting individual function. Finally, we review the related medical history. We ask about previous injuries, general health, medication, and family history. So these factors can influence both recovery and risk of any re-injury. Common symptoms in sports injury vary depending on the type and severity of the injury, but the most frequently encountered symptoms include pain, swelling, warmth and erythema, bruising, stiffness or reduced range of motion, weakness and instability, numbness and tingling. Overuse injuries like tendinitis or stress fracture may have gradual onset of symptoms, whereas acute injuries like sprain, fractures, or dislocation may have sudden, intense symptoms. The slide explains next three important steps in injury assessment, that is observation, inspection, and palpation. We start with observation, which includes checking the athlete's state of consciousness and body language. This gives us immediate insight into their general condition and possible severity of the injury. Here we focus on symmetry and appearance. We also observe motor function, including posture, gait, or any functional limitation. Next, we move to inspection, where we look for signs like swelling, deformity, scars, or any skin changes. Then comes palpation, where we check for joint angulation, swelling, tenderness, and tissue temperature. So we palpate both bony and soft tissue structures to identify pain points, edema, or any other signs of injury. So together, these three steps allow us to make a preliminary judgment about the type and extent of the injury before moving on to special test. Under physical examination test, we begin with functional test. This assesses the range of motion in three ways, that is active, passive, and resistive muscle strength, and potential mechanical restrictions. Next, ligamentous and capsular test, which are special tests for instability, non-contractile tissue involvement, impingement signs, and any vascular issues. The third set is neurological test. This assesses the nervous system using dermatomes, myotomes, reflexes, and peripheral nerve testing. Finally, we use sport-specific tests, which include proprioception, activities of daily living, and skill-based tests tailored to athletes' particular sport. Firstly, about functional testing, which helps to assess the mobility and strength of the injured body part. The images here demonstrate different movements and techniques for functional assessment in upper limb here and in lower limb, this one. These tests are essential for identifying limitation and planning appropriate rehabilitation. For a lower extremity injury, this should be expanded to include willingness to bear weight. Coming to ligamentous and capsular testing, which are used to assess joint function and integrity of joint structures to be performed at a proper angle. So let us list out few tests from many that we use in cases of joint instability and impingement commonly seen in athletes. For upper limb here, common tests include anterior and posterior apprehension test for shoulder instability, Hawkins-Kennedy test and Neal's test for shoulder impingement, scarf test for acromioclavicular joint issues. Coming to lower limb, common tests like anterior and posterior draw test to assess ligament stability in joints like knee and ankle, valgus and varus stress test for collateral ligaments, Latchman test for anterior cruciate ligament, Patrick's test, also known as figure of four sign, which is used for hip joint and sacroiliac joint dysfunction. Lastly, coming to neurological testing, this helps us to evaluate nerve involvement in sports injury. So this includes four main components. First, dermatomes, which are tested to check sensory responses using pinprick or light touch to detect abnormal sensation or loss. Second, myotomes to assess motor function, looking at the muscle strength, body position, and symmetry. Third, reflexes are evaluated through deep tendon and superficial reflexes. And lastly, peripheral nerve testing, focusing on both motor and sensory function of specific nerves, using special compression test and tension test. So these tests are essential to detect any nerve damage, compression, or dysfunction in athletes. I would like to call Dr. Meghna Khatri to catch forward the presentation.
Good morning, respected teachers and seniors. I, Dr. Meghna Khatri, second-year resident from the Department of Physical Medicine and Rehabilitation, will be taking up the sports injuries management and rehabilitation for today's PGCR. Understanding biomechanics in sports is really important as it involves studying the mechanical laws related to the movement or structure of human beings. In sports, optimal biomechanics ensures efficiency, performance, and injury prevention, and conversely, faulty biomechanics disrupt alignment, load distribution, and muscle coordination, leading to an injury. Investigations like posture analysis, gait analysis, running analysis, and foot pressure analysis are done to evaluate any biomechanical factor which might have resulted in the injury. Posture analysis in sports refers to the evaluation of a player's static and dynamic body alignment to identify potential imbalances and measure how different body segments like head, shoulder, spine, hip, and knee with ankles align during rest and activity. Poor posture can be a sign of muscle tightness or weakness imbalance. It can help in detection of faulty biomechanics, preventing overuse injuries, improving performance, guiding rehabilitation, customizing training programs. There are some examples of poor posture in humans that can lead to sport injuries like forward head posture, thoracic kyphosis, lumbar lordosis, and a sway back posture. Example of a polo player who had knee injury and came to us with complaints of knee pain and back pain. After posture analysis, certain biomechanical issues were found that are shown here. The patient had head tilt and shoulder asymmetry with a visible hip hike and pelvic tilt, and a knee valgus deformity of increased Q angle, which is shown. with 17.1 degree rise. He also had plumb line deviations towards the left, with forward head posture and rounded shoulder, and increased lumbar lordosis with increased knee hyperflexion, which is not normally seen while you are standing. In sports, gait analysis is used to evaluate an athlete's walking, running mechanics to detect abnormalities or inefficiencies that could lead to injury or impair performance. Gait analysis can be done qualitatively, done through visual observation, or quantitative, that is done with motion capture, force plates, and pressure sensors. Now, key components that are measured in gait analysis are stride length, which is the distance between the successive placement of the same foot while walking or running; step width, which is the side-to-side distance between your feet during walking or running; joint angles of hip, knee, and ankle while walking or running. It also assesses ground reaction force, which is the force exerted by the ground on the body in response to the body applying force on the ground. The center of pressure is the point location on ground where the resultant GRF vector acts. It represents average position of pressure across the contact surface of the foot with the ground. Now, few images from the report. In mid-stance, when the body's center of mass is directly over the foot, we can observe a significant pelvic hike on the left side during mid-stance, which indicates an abnormal frontal plane pelvic motion, and that may reflect gluteus medius weakness or compensatory gait mechanics. Additionally, we can see that there is right rear foot eversion, which may contribute to altered lower limb alignment and load distribution. Running analysis is a crucial tool in sports injury prevention and rehabilitation, as it helps identify biomechanical inefficiencies, asymmetries, and abnormal movement patterns that can lead to or exacerbate injuries. Unlike general gait analysis, which typically focuses on the walking patterns, running analysis examines the higher impact, more dynamic motions that are involved in running. This includes factors such as stride length, ground contact time, joint angles, and muscle activation during high-speed movement, since running places a greater stress on our musculoskeletal system than walking does. This is how running analysis is done on a treadmill, and the videos are recorded, and after putting it on our system, a report is generated. A few instances from our running analysis at lateral view of a runner who came to us with bilateral shin pain, we can observe both left and right side showed reduced knee flexion and increased tibial inclination at initial contact, indicating overstriding and suboptimal shock absorption during running. Running analysis identified the root cause of injury, and most sports injuries are not caused by a one-time trauma but by repetitive stress or poor mechanics. Now, poor running form can lead to a variety of common injuries like overstriding, which is where the foot lands too far in front of the body, and it increases impact forces that can lead to shin splints and knee pain. Another common issue is hip drop, which is often caused by the weak glute muscles, which creates an instability in the pelvis and is closely related to the iliotibial band syndrome. Additionally, poor foot alignment, such as excessive pronation or supination, can disrupt body's natural movement patterns and can cause plantar fasciitis. And without correcting these, you are just treating symptoms, not the cause. Foot pressure analysis, also known as plantar pressure mapping or pedobarography, it is a valuable tool in sports injury management. It involves assessing how pressure is distributed across the foot during standing, walking, or running. This data helps diagnose injury causes, guides treatment, and prevents re-injury. It uses pressure-sensitive mats, insoles, or platforms to measure peak pressure points, contact time and pressure distribution, center of pressure path, and foot loading patterns. It can be done in static, which is standing, or dynamic walking or running form. This is the pedobarographic 3D model, where the red area shows heightened pressure and the blue area shows low zones with the intermittent shades showing the range of pressures from red to blue.
We have this equipment with us.
In this report, the average matrix left highlights higher pressure at the heel and forefoot region, especially on the right side, which bears 36% of our body weight compared to 27% on the left, which is not normal, and it indicates mild asymmetry. The middle matrix marks peak pressure points, again showing the right side dominance. And the weight distribution chart on the extreme right shows 53% of total load on the right foot. Clinically, this suggests compensatory offloading on the left side due to pain or any other reason. The center of pressure path represents the movement of point when the ground reaction force acts on the body. During gait walking, the COP follows a smooth, curved path from the heel to the toes of each foot, typically forming an S-shaped trajectory. This movement represents the progression of body's weight through stance phase and is usually symmetrical in healthy individuals. Deviation in these patterns can indicate balance or gait abnormalities. Now, certain common conditions that sports people come to us with are patellofemoral pain syndrome, which is often called as runner's knee. It is a common issue amongst runners and is typically linked to biomechanical problems like knee valgus, where the knees collapse inward, and excessive hip internal rotation with overstriding. Gait analysis helps identify poor hip control, often due to weak glute muscles, and by strengthening them, especially the glute medius, runners can improve alignment and reduce stress on the knee. Key movement patterns that are linked to iliotibial band syndrome include a pelvic drop on the opposite side during the stance phase and excessive hip adduction. It often reveals weakness in the glute medius and pointing to the need for targeted strengthening. It also helps adjust stride width and improve hip and knee alignment, which together can significantly reduce strain on the IT band and lower the risk of recurring pain. Hamstring strains or recurrent pulls are often tied to poor running mechanics. A common issue is overstriding, which causes the hamstring to overstretch as the leg reaches too far forward. Along with poor core control, it puts excessive strain on the hamstring, and by addressing these, runners can improve pelvic stability, reduce hamstring strain, and lower the risk of knee injury. Shoulder impingement syndrome, the main biomechanical issues include poor scapular movement, weakness, or imbalance in the rotator cuff muscles, along with postural problems like rounded shoulders or a stiff upper back. These falls reduce the space under the acromion and causes the tendons to get pinched during overhead motion. To correct this, we focus on strengthening the rotator cuff and the scapular stabilizers, improving posture and thoracic mobility. Tennis elbow or lateral epicondylitis, which often results from biomechanical faults that places excessive strain on the forearm extensor muscle, particularly the extensor carpi radialis brevis. One common fault is the overuse of wrist extensors due to repetitive or forceful wrist movements, which can be corrected through eccentric strengthening exercises, stretching, and the use of counterforce braces to offload the tendon. Now, management in sports injuries is crucial and should be addressed early to prevent minor injuries from developing into more serious long-term problems. Early interventions help reduce pain, swelling, and the risk of further damage, allowing for a quicker and more effective recovery, and it can be done under 4 pillars comprehensively: pharmacological management, non-pharmacological management, rehabilitation, and return to sports. Immediate care after sports injury consists of PRICE, where P stands for protection of the injured area and preventing the further injury by using braces, splints, or immobilizers in general. Here are some examples like ankle, knee, wrist, and elbow immobilizers. Rest, where we allow the injured area time to heal. I stand for ICE, which helps in reducing swelling and pain in acute conditions. C for compression, which helps in minimizing swelling and provides support. E for elevation, which helps by raising the injured area above the level of the heart and helps in reducing the swelling. Pharmacological management plays a supportive role in facilitating early rehabilitation in sports injuries. Goals are to relieve pain, reduce inflammation and swelling, promote comfort during healing, and allowing participation in rehabilitation as well as functional recovery. Certain medications that are shown here can be given in sports injuries, like analgesics for mild to moderate pain without inflammation, NSAIDs that can be given for pain, inflammation, swelling, in examples of sprain, tendinitis, and contusions. Topical NSAIDs can be given for localized muscle or joint pain, muscle relaxants for muscle spasms and strain-related pain. Opioids, which are rare in sports, can be given after a severe acute pain due to surgery or fracture. Supplements can also be given for joint health and long-term cartilage support. Certain injectable therapies like corticosteroid, platelet-rich plasma therapy, and prolotherapy can also be given in conditions where corticosteroids can be given in more acute conditions like tendinopathy, bursitis, plantar fasciitis, and synovitis in overuse injuries. PRP can be given for chronic tendinopathies, muscle tear, ligament strains, and early joint degeneration in athletes, whereas prolotherapy can also be given in chronic conditions like chronic ligament tendon injuries, joint instability, and chronic groin or back pain. Non-pharmacological management includes therapeutic modalities, orthotics, activity modification, and rehabilitation inside of it. Therapeutic modalities play a key role in sports injury management by reducing pain, promoting tissue healing, and restoring function. Cryotherapy or cold therapy is most effective in acute phase of injury, typically within the first 48 to 72 hours, and is used to manage swelling, pain, and inflammation. It involves applying ice packs or cold compress for 15 to 20 minutes every 2 to 3 hours, always with a protective barrier like a towel to avoid frostbite. In contrast, thermotherapy, which is also known as heat therapy, is used for subacute or chronic injuries, particularly when dealing with muscle stiffness or joint tightness. Heat is applied using hot packs, heating pads, or warm baths for similar durations. But it should be avoided during the early stage of injuries as it can increase inflammation. Ultrasound therapy, another widely used heat modality, which is used especially in chronic muscle and joint issues, tendinitis, or ligament injuries. It uses sound waves to promote deep tissue healing and is typically administered in short sessions of 5 to 10 minutes, 2 to 3 times per week. Each of these modalities has specific indications and timing to maximize their therapeutic benefits and support recovery. Electrical and acoustic based therapeutic modalities are essential tools in managing both acute and chronic sports injuries. Like TENS, which is also known as transcutaneous electrical nerve stimulation, is commonly used for pain relief by placing electrode on the skin around the injury site. It delivers electrical impulses that stimulate sensory nerves to block pain signals, typically during a supervised 20 to 30 minute session. For muscle rehabilitation, electrical muscle stimulation (EMS) is used to address muscle weakness, particularly after injury or surgery. EMS works by causing controlled muscle contraction through surface electrodes, which help re-educate muscles, improve tone, and restore strength. Another advanced modality, extracorporeal shockwave therapy (ESWT), uses high-energy acoustic waves to stimulate tissue repair and regeneration, especially in chronic hard-to-heal conditions. ESWT is particularly effective for tendinopathies like plantar fasciitis, Achilles tendinopathy, patellar tendinopathy, also known as jumper's knee, and lateral or medial epicondylitis, along with chronic muscle injuries, including persistent myofascial trigger points. Orthotics and shoe modifications are essential non-invasive tools in sports injury management as they help correct biomechanical imbalances, redistribute the pressure, and reduce strain on injured tissue. It helps in improving alignment and posture, correct abnormal gait patterns like pronation or supination, provide cushioning and shock absorption, offload the pressure from injured or painful areas, and support healing and prevent re-injury. Purposes certain orthotics that are used in sports injuries or any other common conditions are heel cuffs that can be given in plantar fasciitis, heel lifts for Achilles tendinopathy, medial arch support for patellofemoral pain syndrome, shock absorbing insoles for shin splints, and metatarsal pads for metatarsalgia. Activity modification is a fundamental component of sports injury management. It is aimed at allowing healing while maintaining overall physical activity level. In some cases, this means complete rest, which is temporary sedation or complete rest of the aggravating activity, such as stopping the running and jumping part, which aggravates the pain for a defined period. More commonly, it involves reducing the intensity, frequency, or volume of activity, such as training at a 50% effort. Cross-training with alternate low-impact exercises like swimming or cycling can help maintain fitness without stressing the injured area. Technique adjustments such as changes in the running form or lifting mechanics can also minimize the changes in strain. Equipment modification like using braces, orthotics, or supportive footwear further support recovery and reduce re-injury risk. In team sports, modifying the athlete's position or a role to a less demanding one can allow participation and while minimizing the physical load on the injury. Rehabilitation in sports injuries has many goals, which are to provide pain relief and inflammation control, to restore the range of motion, to regain strength and endurance, to improve flexibility and mobility, to rebuild proprioception and coordination, address the psychological readiness of the player, and ensure a safe return to play. This graph illustrates the concept of optimal load for recovery during rehabilitation after a sports injury. It shows that recovery is not a straight path, but it involves fluctuation in the activity levels, which is a normal part of the healing process. And temporary setbacks or symptom flare-up may occur, but with consistent and appropriate progression of the rehabilitation load, overall functional improvement continues. This emphasizes the importance of a graded rehabilitation approach, where symptom fluctuation is expected and does not indicate failure or re-injury. It can be done in 4 phases, where acute phase, which accounts from 0 to 72 hours, our main goals are to reduce pain and inflammation, protect the injured area, and minimize loss of function, which can be done by giving pain-free range of motion, isometric exercises, or breathing and relaxation exercises to provide calm to the player after the injury. It can be done in subacute phase, which is from 3 days to 3 weeks, and our main goals are to restore mobility, begin strength building, improve circulation by starting the active range of motion, gentle stretching, light resistance band exercises, proprioception, which is balance board and single leg stands, and stationary cycling or swimming if the patient is pain-free. Remodeling phase, which typically accounts from 3 weeks to months, our main goals are to rebuild strength, endurance, and coordination. It can be done by giving resistance training, body weight machines, or free weight workouts, dynamic stretching and mobility, balance and agility drills, plyometrics, and low impact cardiovascular training. Return to sports phase, which is where our main goals are to return to the pre-injury level to prevent any sort of re-injury and for the psychological readiness of the player to get back into the game. We can give high intensity plyometrics, agility and reaction drills, cutting, pivoting and sprinting if relevant for a run-up, movement pattern corrections and core joint and stability training. Now, the return to play is the final stage of sports injury rehabilitation, which focuses on restoring the athlete to their pre-injury performance level while minimizing the risk of re-injury. There are certain criteria like the patient should have total absence of pain at the site affected, especially during sports movements. There should be absence of symptoms during any pain provocation test at the injury site, along with absence of abnormalities in imaging examinations, and patient should be pain-free for 10 to 14 days with 10% increase in training intensity per week. Now, I would like to call Dr. Regdhara Mishra to continue the cases that had come to us in our department and how we managed them.
Let's discuss few cases. Coming to first one. A long distance runner aged 28 years came with complaint of dull aching pain in the posterior ankle region since 6 weeks, and it seems to get worse since past 1 week. Although he appeared to have good body symmetry, he was unable to raise up on his toes or walk without an antalgic gait. According to NRS, that is numerical rating scale of pain, the pain was 6 on 10 while walking and 9 on 10 while sprints. On examination, there was local tenderness and swelling. Leg heel raise was difficult. Arc test was positive. Joint stability tests were negative, and the individual had normal bilateral sensation on the feet and good distal pulse. So, what do you think? What should be the differentials here? Yes, you're correct. The possible differentials here are ankle sprain, Achilles tendinopathy, and retrocalcaneal bursitis. So, on investigating, we found that ultrasound demonstrated thickening and rounding of affected portion of the left Achilles tendon. As we can see here, this is the left one, and this is comparative right side. On MRI, there was marked thickening and increased signal of distal part of the Achilles tendon, consistent with tendinopathy, along with extensive edematous changes visible around the tendon, keeping with peritendinitis. So the diagnosis here is Achilles tendinopathy, typically seen in runners and athletes. Coming to management.
If it is because of running, it should be on both sides.
So usually it is subjective actually, because some people, they have more pressure on single leg.
So his technique of running is wrong.
Overuse effect on that leg. So maybe initially it comes to one leg and then might come to another leg depending.
What is the grade of running for these symptoms to develop? Like if we do morning running, what is the strength and intensity of this running to develop?
It depends on multiple factors, on the muscle bulk, muscle strength, how much warm-up the patient is doing before any kind of such activity, and the shoes, how are they cushioned, whether they are...
General public doesn't do any warm-up exercise. General public doesn't have proper shoes for running, but they still run. So what is the advice?
We advise proper warm-up to be done before going for a run, using special equipment and special shoes for that, which are good cushioning and good insole and outsoles are present. So,
Proper fit shoes.
coming to management here. We started with... Let's come to next case. A 29-year-old software engineer male who regularly goes to gym, and he came with complaint of dull aching pain in the lower back and upper pelvis on the right side since 3 days after deadlifting approximately 120 kgs in gym. Pain gets aggravated on lateral bending, prolonged sitting and standing, whereas relieved with rest and also after hot fermentation. On assessment, there was local tenderness over right iliolumbar region lateral to L5, just above posterior superior iliac spine. There was sharp pain on movement, which was non-radiating type. Spine alignment was normal, and on performing Patrick's and Newman's test, they were positive, whereas straight leg raise test was negative. So now in this case, what should be the differentials? Any guesses?
I think it can be disc bulge, disc protrusion, and disc injury.
Let's look at the differentials here. Can be lumbar disc herniation, as mentioned by him, piriformis syndrome, or iliolumbar syndrome. On investigating, we found that under ultrasound there was hypoechoic disrupted appearance with inflammatory signs on the location. On MRI, which is gold standard here, showed mild edema and thickened right iliolumbar ligament without any disc herniation or vertebral abnormality. So the diagnosis of this case is iliolumbar syndrome of right side. And this was the management given in this case.
All the PMR residents, are they taught how to do musculoskeletal ultrasound? Why not?
We are not having any machine with us.
But
And,
you should send them to radiology.
No, we are doing that. From this batch onward, we'll start. Previously, we were not having EMG and all those. They are procuring in phases. So now we are having video scan, we are having EMG, we are having gait lab, and all those things.
If you think I personally think it is an important part of
Yes,
their
sir.
training, I think you should put a demand through the medical director.
Yes, sir.
And,
That is already in process. Under
because they by the time they finish, they should know how to evaluate muscles and joints on ultrasound.
yes.
Coming to third case, a 21-year-old fast bowler came with gradual onset of pain in the mid-shin of the right hip. Pain began 3 months ago initially after long bowling spells and persisted even during walking. He described the pain as localized sharp during activity and dull at rest since 1 week. It has worsened with running and on impact. About training history, he mentioned there was recent increase in bowling workload from 30 overs per week to 60 overs per week with no previous injuries. On examination, there was localized tenderness on the mid-third of the right tibial shaft, no deformity or swelling. Full range of motion was seen at knee and ankle. Function test showed there was pain with single leg hop test, fulcrum test, and pain on resisted dorsiflexion due to stress on tibialis anterior. So what could be the possible differentials here?
It can be shin strain, it can be stress fracture, or any compartment.
Yes, correct. So these are the differential diagnoses: anterior compartment syndrome, shin splints, tibialis anterior, muscle strain, and stress fracture of tibia. On investigating, we found that under X-ray, there was presence of sclerosis, cortical thickening due to periosteal reaction, and a fracture line at the site of pain. On MRI, there was bone stress reaction with ill-defined hyperintensity area on fluid-sensitive sequence of MRI with some microfractures. On gait analysis, there was overstriding with hard heel strike and overpronation on foot analysis. So the diagnosis here was tibial stress fracture. This was the management given. Now we'd like to call Dr. Sonu sir for concluding the presentation.
Now, in conclusion, I can say sport management of sports injury is not only managing pain. It must be, you can improve, you can touch peak injury level, you can improve performance, and most importantly, prevent recurrent injuries. Ultimate goal is to rehabilitate to facilitate a safe and effective return to your sports activity. And with right approach, you can come back stronger and more resilient than before. Like in that case, we have shown that walking video. Is Yash Thakur, basically under 19 Indian cricket player. He represented Indian. He was highest wicket taker in under 19 World Cup. But during last IPL, he injured. But despite injury, he continued playing. Now, soon after injury, he sent back to NSA, National Cricket Academy, Bangalore, where he was rehabilitated for 3 to 4 months. Then he contacted. He was my old, you can say, patient also, and one of my good friends. I used to play with him also. So he came to Jaipur. We treated him, but he again sustained injury in next IPL. During this assessment, this follow-up, I assessed his gait and video scans. After video scan, soon after video scan, he becomes totally pain-free and his X-ray shows excellent recovery. Now he is free from an injury, he is regularly playing and he was among probable for Asia Cup also. That's it. So ultimate goal is to correct biomechanics and prevent recurrent injuries. Thank you.